Of course, healthcare is messed up. The incentives are all wrong. Okay. Now, this is not just some like armchair comment from Charlie Munger. He actually was on the board of directors for a hospital in Los Angeles for like 35 years.
Good morning, Dr. Bricker. Hey, it's really great to be with you today as we're talking about a topic I've spent my whole career, and I know you've spent your whole career talking about, is healthcare cost.
Well, great to see you, Wally, and thank you so much, everybody, for watching and listening.
Hey, when I think about our topic today, I really feel like it's a return back to the future. Like literally from when I started my career in the early 90s, and you and I have been around the industry, right? We've been on the provider side of the industry, the benefit consulting side of the industry, the insurance side of the industry. We started point solution companies. Like we've been around, and this seems to be the same topic we've always discussed. It's certainly the topic that you've done an amazing job of educating the country on with your whiteboard videos and A Healthcare Z. As you reflect on all of that education, what's sort of your biggest takeaway?
Yeah. So, healthcare cost can be, it can be a pretty boring topic, but, as a physician, I think about cost as really the main driver for access, right? If you can't actually get access to a clinician and healthcare services, then it's like all for naught. Like quality doesn't matter, like outcomes don't matter. If you can't actually get the care, then that's kind of where it starts. And so if the care is too expensive and you can't access it, well, then that's a huge problem. And so I really look at solving the cost problem for employers and employees really as a physician. I look at it really as an access issue. And I think in that way, it's not just about the money. It's really about the underlying health and the care for the employees and their families.
When I think about that, and I totally agree, it's just been hard for employers and physicians and hospital administrators and insurance companies to stay focused on the people, the patients, the member, because when we compare our inflation rates to wages, to what percent of our GDP, like it's just not sustainable. And again, I feel like we've said this for decades now, but the numbers have just gotten so big. Like I don't even have to quote them on this, on this webinar because everybody knows, right? Everybody knows this has just gotten so big that the emotions behind it are greater than it's ever been.
Yeah, and I would add too, because of course, the famous Warren Buffett quote was that healthcare is the tapeworm of the U.S. economy. But what's really happened from a cost perspective is that before it was like, okay, well, if you were lower income, then okay, you had a really hard problem affording healthcare. But now healthcare has become so expensive. It's like, well, now if you're like middle class, healthcare has become like unaffordable. And then like it's gotten to the point where even if you're like in the top like 10% or 5%, essentially, if you're like in the 99% and you're just like not in the 1%, for a lot of folks, it's just too expensive. And so you really
Yeah.
have created an access problem, not for just a small portion of America. You've actually created an access problem for like the majority of America.
Yeah, it's so true. And when I think about almost 20 years in benefit consulting, what we talked about with employers to try to help them feel like they had control over their spend is we try to simplify it into an algebra equation. I told my parents when I was growing up in school, like, why do I need algebra? I'm never going to use algebra in my career. But literally, this equation has been my whole career. It's around price of services times the amount of services we use. Like that equals our ultimate cost. And we have thrown a lot at both sides of price and use. Think about your time at Compass. Talk a little bit about when you were, the chief medical officer, one of the founders at Compass. Talk about what you learned during those years.
Yeah, so this really is the most important equation in healthcare, right? So everybody who works in healthcare has to know. The good thing is that it's a simple equation, right? So like the your overall healthcare cost is the price of an MRI times the number of MRIs that your plan has, or the price of a surgery times the number of surgeries that you have. So you go across that for like all the different services and medications that your plan spends money on. Okay, fine. So what we really learned at Compass was that at the end of the day, it's not a question of focusing on just the unit cost. it's not a question of just focusing on the utilization. It's really a matter of, to really address the cost problem, you really need to address both. But you don't need to do it in a way where you're addressing like all prices for all healthcare services everywhere in America. And you're not addressing like all utilization for all healthcare services across your employee population. In that, it really is addressing the things that, I'm a big fan of Stephen Covey, and he talks about the circle of concern and the circle of influence, right? So maybe like all prices in America and all utilization for your health plan, maybe that's of concern to you, but at the end of the day, you cannot influence that. Okay, let's be realistic, right? So then, okay, well, what are the focused areas of influence that you can have around price? What are the focused areas of influence that you can have around utilization? And like that is a very doable task, and many other companies in America have used that approach like very successfully, and that's a big part of what we're going to talk about today.
So, Eric, when I think about that equation, and I beat this drum hard over the years, I'm now realizing there was something missing from it the whole time, and that was AI. But I'm not talking about artificial intelligence. What I'm really talking about is aligned incentives. Like reflecting back now, it didn't matter how great our pricing strategies were and how great our utilization strategies were. We have really learned that unless we have aligned incentives, we're never going to get ahead of cost. I'm curious from a physician perspective, and you've seen it all. What do you think about when we start to double click down on aligned incentives?
Yeah. So again, I'm gonna use I'll use a Berkshire Hathaway quote, this time from Charlie Munger, the vice chairman of Berkshire Hathaway. And so he said, "Of course, healthcare is messed up. The incentives are all wrong." Okay. Now this is not just some like armchair comment from Charlie Munger. He actually was on the board of directors for a hospital in Los Angeles for like 35 years. So he actually has a lot of experience in healthcare and dealing with a lot of the issues that clinicians and the healthcare system have to deal with. And he, smartly recognized that, look, if you don't get the incentives right, then pretty much everything else is just window dressing, right? So, of course, with all of our, our innovators and our technologists, right? You listen to them and they're always like, it's super important to talk about first principles, right? First principles, right? Okay, right? Well, shoot, the first principle is the incentives. So that's why it's so important.
Go back to the 1900s, when managed care was really in its heyday. And I'll confess, I was the president of an HMO. And, we had reworked our network models where, a large percentage of the care was done on a capitated basis, not a fee for service basis. Providers received a fixed amount per month for every member that was under their umbrella, and they had to take care of those patients for that fixed fee. And if their cost for servicing and treating those patients was more, they didn't make money. But if they were able to do it efficiently, they made money. And you know what? I will also tell you, because I left the provider system, during that season. We had to close one of the wings of our hospital, Dr. Bricker, because we didn't need all the beds anymore because we weren't incentivized just to do more services.
Yeah.
We had fewer admissions, we had lower costs. Like it was the one time I can reflect on when incentives were the closest to being aligned, and healthcare inflation was not only lower, in some places, we were actually in a period of deflation.
Yeah, and this kind of go to your point about this going on for forever. So Sam Walton, the founder of Walmart, he used to have these Saturday morning meetings with his executives. So if you worked at Walmart, if you were an executive at Walmart, you had to work on Saturday morning. So they and of course Walmart's a big company. They had like a whole bunch of executives. It wasn't like 5 people; it was like 50 people in a room. And Sam Walton would talk on a microphone so that everybody could hear him. And this is a clip from probably like the 80s, even, because Sam Walton actually looks like a relatively young guy. He's wearing his baseball hat, and he's talking about literally the price of an MRI for Walmart employees being hugely expensive, and how, Walmart's getting killed by our healthcare costs. So here you have a long time ago, the CEO, obviously Walmart's, key to success is they're able to provide low prices for people because they're the low cost acquirer, right? They're the low cost purchaser, right? Well, they also needed to be the low cost purchaser of healthcare, and so they knew that they were getting killed a long time ago in regards to cost. So from a cost perspective, managed care totally worked. However, there was a big but associated with it, and I think we're going to
You
talk
know,
about that but.
yeah, the big but was that as Americans, we absolutely hated it. Like this was a magazine cover from 1999, November 99, HMO hell. Like literally Americans, had a backlash on how dare you as my insurance company tell me whether I can have a service or not, what gives you the right? The mother may I, have a service with a referral, to a specialist or approval for a procedure, and employers did not like the narrow, high performing network. They wanted to make sure that every hospital was in your network and every physician was in your network. And I remember comparing, which networks had the most hospitals and doctors because nobody wanted, to be restricted. And unfortunately, all of those incentives that were aligned, they went away, and we ended up replacing them, with a fee for service model where the more you do, the more you make as a provider. So Eric, talk a little bit about, fee for service and the good and the bad of that from your perspective.
Yeah, well, I think part of the backlash against HMOs is at the end of the day, like we in America, we like freedom, right? That's what America's about is freedom, right? And so to a certain extent, like all the rules associated with HMOs, at the end of the day, they're kind of un-American, right? If you were like, this is not, this is like in the 80s, there was still the Cold War going on, so it's like this is not a communist country, right? The point is that we have choice and we have freedom in America. Like, and I think that's right. Like, I think that's the right way to like look at this. So to your point, there was like the backlash, and so we're like, okay, now we're going to have the fee for service where the docs and the hospitals and imaging and surgery and all this sort of stuff. It's not fee for service is exactly what it sounds like. It is money for doing something. It is payment for action. Okay, okay, that by definition it's not called fee for outcomes. It's not called fee for health. And at the end of the day, like I can tell you as a physician, when I see patients, like people don't want stuff done to them. Like I don't know very few of my patients were like, "Oh, I can't wait to have this surgery because I'm bored." Right? It's like they don't want to have stuff done. What they
Right.
want is relief. They want function. They don't want to, they want longevity. I mean, not to get overly morbid, but we're trying to present to a certain extent prevent premature death here, right? And so paying for stuff is not always the best way to achieve that end of health. And so here we have, from an incentive standpoint, we've got all of the clinicians, hospital systems, physician groups, et cetera, they're financially incentivized to do stuff when doing stuff 100% sometimes is the best thing to do to achieve health. Like I'm not saying don't do stuff, don't do interventions, but I'm saying that the financial incentive should not be to just do stuff, because sometimes it makes sense to be um it here's what it makes sense. It makes sense to follow the science. It makes sense to follow the evidence. So when I was in medical school, they said, listen, science is the mother of medicine, right? We don't do stuff willy-nilly, right? We do stuff because there's evidence to do it. And so, right, so what's the right way to create incentives for clinicians so that they follow the evidence, so that they do what the science says? And fee for service is not the best way to do that.
Do you think that providers
Oh,
are
I'm going to say
influenced?
clinicians. That's the new word, by the way,
Oh,
because
clinician.
because
Do you
doctors and
think
hospitals hate to be called providers, so we're going to call them clinicians.
do you think clinicians are influenced by the financial um, and not only the science?
So the answer is yes, but here's where it's sneaky, is that so much of our decision making is subconscious. So are there a percentage of doctors and hospitals out there that are consciously making decisions to do stuff to make more money? Sure. What percentage is that? It could be 5%, it could be 10%, it could be 50%. Like, I don't know what that percentage is. In my estimation, it's probably a relatively small percent. However, there are many subconscious things that are done to still have it be the influence without people talking about it. Let me give you a specific example of that. Okay, fee for service incentivizes a lot of services. Well, what's a very basic service that we do? It's office visits. And so fee for service incentivizes a lot of office visits so you can bill more fees for those office visits. Okay, well, how do you fit more office visits into a day? Well, you could either add hours to the day or you could shorten the length of the visit. And so the visit lengths are very short, right? So the average clinician in America spends between 5 and 10 minutes actually with a patient, and then the overall visit is like 15 minutes, but they're spending half the time on the medical record, so they're not actually spending it with the patient. So what we've done is systematically created a schedule and quotas for physicians to see a patient every 15 minutes, and like nobody is consciously saying, well, I'm just doing this to make more money. No, it's just it has structurally been put in place because of fee for service. And as a result of that, and I'll just be very quick on this, we say, oh, I don't have a lot of time. And so the way for me to save time is, instead of for me actually like asking you a detailed history and forming a relationship with you and performing a good physical exam on you and then explaining what I think, all of that takes time. And so it's actually a lot easier for me to get my 15-minute visit done and be like, okay, well, you've got a sinus issue, we're going to send you to ENT. You've got some heartburn issues, we're going to send you to GI. You've got some minor rash issues here and some eczema, we're going to send you to dermatology. And so that, as like the primary care physician, that has quote unquote saved you time. But then you've just created three additional visits, not because you're just trying to make money, but again, because you're sort of systematically and structurally in this fee for service environment that, guess what? It creates more services, not necessarily to the benefit of the patient.
Eric, as I think about fee for service and the move away from capitation, which, we were in the middle of that season when incentives were, mostly aligned, not perfectly. And then we moved to fee for service, like without question, the internal discussions we were having when at the hospital, I was with, were how do we make sure and keep our patient volume high? How do we make sure that our MRI machine is always scheduled out? And even though our physicians were focused on delivering care consistent with clinical guidelines, we were measured by, were we also keeping our beds full? Were we also, utilizing our technology all the time? And honestly, we moved from utilization being managed to utilization honestly being incentivized. Unfortunately for employers, they saw that backlash to managed care, the move to fee for service, really start to drive utilization. So we did what we thought was the right thing to do, and that was to focus on let's really start to reduce utilization by improving the health of the population. Started with disease management. I remember the introduction of diabetes programs and cardiovascular disease programs and asthma programs. Like, if we can just focus on those individuals with a chronic condition, which by the way represents, the majority of us in the country with having one or more, chronic conditions, then we can actually reduce cost. But I think that the big flaw in this was we were focused on reaching out to individuals, when it was kind of too late. They'd already developed their chronic condition. And that really led to the introduction, obviously, of wellness programs. And everybody's like, let's just keep everybody healthy. If we can just keep them healthy, they won't develop a chronic condition, and then our healthcare costs will come down. And honestly, that really didn't move the needle either. Does that surprise you that disease management and wellness and all the solutions that were born out of that didn't really move the needle on inflation?
Well, I could tell you as a physician, like I thought that was my job. I mean, I became a physician to help people thrive, right? And like I didn't like no one like you can to a certain like I don't know maybe whoever came up with that term disease management, like maybe they're
I
from the
know.
insurance industry. I mean, what a terrible name. Like
Terrible.
nobody went into taking care of people to quote unquote manage diseases. I mean, so yeah, I mean, you would help people thrive. And so, right, it's like, okay, well, like for thousands of years, okay, since like Hippocrates in ancient Greece, right? It we went to the doctor to thrive. Okay, the doctor is not a new doctoring is not a new profession. Okay, and so it's like, okay, you mean to tell me that within like human culture across societies, we've had this thing called a physician or a clinician because the word physician means to teach. They're teachers. Okay, so we've had this for thousands of years, and you mean to tell me we're just going to create this new class of people that are going to miraculously keep people well? Like, I don't know. I just wouldn't want to fight against thousands of years of history. That probably is not a good idea.
You talk about going to doctors to thrive. I can tell you, I can't think of the number of wellness programs, too many to count, that actually use the name Thrive in their name. Like that was actually the name of a lot of wellness programs.
Right? Which is
You know,
fine. That is a fantastic goal. I'm 100% on board with that. But in the mind of people, it's like, okay, yeah, I want to thrive too. Well, like I go to the doctor for that.
absolutely. You know, I think the reality is for the last, 10 plus years, like employers have been throwing everything against the wall, trying to find the solution, the point solution, that would lower healthcare spend. The statistics almost hard for me to wrap my head around that for large employers, they have between 20 to 40 vendors. Like that's just unbelievable. But you talk about, hey, this was my job as the doctor. This has obviously created a fragmented experience, and it's not flattened the trajectory of healthcare trends.
Yeah, and so I think this is my own explanation for why this has happened. It's because point solutions make great business plans, right? Because they're like, hey, we have fantastic gross margins, and it scales tremendously. I kind of liken it to a teleportation app. Like if you developed an app on your phone that could teleport you, like you could go to investors and you could be like, oh, this is high gross margins. All you do is push a button and it just puts you wherever you want to be, right? Except the teleportation app didn't actually move you from one place to another. All it did is it just showed you a picture of the other place. So that's the
Absolutely.
point. The
Absolutely.
point is teleportation apps don't work, right? So yeah, but they have huge gross margins, right? Yeah, gross margins for something that doesn't work, right? That just shows you a picture of Hawaii instead of actually taking you to Hawaii, right? So like that's essentially what's happened with point solutions is that you've got all these companies that have fantastic business plans, but at the end of the day, it doesn't work. And so if it
Absolutely.
if it doesn't work, if you're a patient, you're like, I'm looking at a palm tree and a picture of Hawaii, but I'm not in Hawaii. So like if it doesn't work, then you've kind of missed the punchline.
Hey, and listen, I led, point solution companies and products and distributed them and we built them, but they didn't move the needle. And I think what we've realized now is whether we're talking wellness or disease management or just the dozens of point solutions, like think of it like an auto store. Like you want an auto part, well, we've got 14 spark plugs, just like we have 14 weight loss programs. Which one do you want? Like it just hasn't moved the needle because none of them at the end of the day fix the incentive problem. And I think we've ended up in an environment where healthcare is behaving like exactly the way we've designed it. Providers are paid for volume. The more they do, the more they make. Employers want better value with lower utilization, not higher utilization. But with incentives being misaligned, we're just never going to get ahead of the curve. Thoughts on that, Eric, in terms of is it really that step three that without incentives, we never get ahead of the curve?
So the short answer is yes, and this is where it gets a little complicated in that um, from in my experience, the challenge has been that historically, again, this kind of goes back to like the 80s and early 90s with like communism versus capitalism. Is like, okay, well, we'll just have the same incentive for everyone, right? And everyone, look, we are very unique individual people. And so the point is that every person's incentives are actually different. They're unique to them. And so, as a clinician, one of the things that is so vital to, and we always talk about like the doctor patient relationship. Part of that relationship is you're trying to figure out how that other person ticks, right? Everybody ticks in a unique way, right? And we don't use the word like, well, what motivates you, but it's like, okay, like it's very different for different people. Sure, for some people it's money, for some people it's relationships and it's belonging. For some people it's time. They're very motivated by, whether it's spending more time on one thing or less time on something else. And so it's very important. And by the way, this has been like researched and codified and implemented, and it's called motivational interviewing. So it's actually an approach that was created by an American psychiatrist from New Mexico. Okay,
Mm.
one of the most amazing things that come out of New Mexico was motivational interviewing. And it's where, just very briefly, it's where the clinician really meets the patient where they are. Well, what are your goals? What are you interested in? So we as a wellness vendor, as a point solution, or as an employer, we've got our priorities. But the key is you got to figure out to the patient, what are their priorities, and you got to meet them
Interesting.
where they are. And so, guess who has adopted motivational interviewing more so than anywhere else in the world? The British National Health Service, right?
Mm.
Which is where they have, people that are, the clinicians are trying to take care of a population. There's a longitudinal relationship. They're not getting their care through their employer. It's just the local primary care doc down the street. And especially in Wales, of all the places in the UK, it's actually Wales that uses motivational interviewing. And like, listen, it's not perfect. It's not a silver bullet, but it's hugely helpful in improving the health of, because that's the ultimate goal, right? That's the goal of the patient, that's the goal of the clinician, is you want to improve the health of the individual. And so that approach of figuring out how that other person ticks and what actually motivates them and what they're actually interested in improving about their own health, that's the key. The key is not some sort of like magic abracadabra incentive that is great for all people. That doesn't exist. It's in the particular, not in the general.
Eric, as I think about, you use the example of what's happening in the UK. I don't want to get my healthcare in any other country than the United States. I think we have the best healthcare system in the world. But are the outcomes that different or any better in the United States with our utilization excess? There's no argument on that, right? You're more likely, to receive a high cost medical service in the United States for a given condition than you are in any other country in the world. So, like, how do we reconcile that?
Okay, yeah. So the reason is that we have the best healthcare in the world in pockets for some people. So it's like to talk about healthcare in America is like talking about the weather in America. Is the weather in America all the same? No. The weather in America is not all the same. What's the average temperature in America? Well, the average temperature in America is a completely useless statistic, right? You want to know what it is where you are, for you in particular. I remember one time my son and I went on a fishing trip in San Diego in the summer, and he walked out of the hotel and it was, no clouds in the sky, 70 degrees, no humidity, no bugs. And he looked around and he said, this place is perfect. and he's right. It was perfect, right? So yeah, U.S. healthcare is perfect in very specific spots for in very specific people, but that doesn't matter for you. Like if it's perfect somewhere else, well, like I care about like what's going on with me right now, and if it's not perfect for me, well, then that's a problem. Again, it's an
Yeah.
issue of solving the specific, not solving the generalities.
Well, that's a really interesting point, and as I think about expanding where healthcare can be perfect. We learned a lot during the season of alternative health plans. We launched the program Simple Pay and Coop Health, and then we sold that company, and now alternative health plans are a kind of a core, model for health insurance. And what we learned is that we really, once we started to get more hands on with network strategies, we started to see the most impact we were having. In many ways, it accumulated everything we'd learned around, aligned incentives, around high quality care, utilization, like everything kind of came together, and that's really gotten us motivated to take it to the next level. So like what builds on, alternative health plans, and it's what I know we're calling right now together direct care. We think that's the future network strategy that puts it all together. And I know you've been, the tip of the spear on this, really leading the charge for us nationally. Let's define direct care plans. Always want to compare it to direct primary care. This is not DPC. This is DCP. These are direct care plans. Talk a little bit. Let's define that for our audience today and really help them sort of wrap their mind around what's next as it relates to aligned incentives and network strategies.
Yeah, and so this is where we're going to get into a little bit of like the healthcare wonky stuff. So we're going to start using a little bit of healthcare nerd terminology here. So, but bear with us. Focus, stay focused, everybody. You're doing great. Stay with us here. Is that listen? At the end of the day, one of the biggest so again we're going to apply the innovators approach of like first principles, right? So we've been talking this whole conversation about a lot of like the first principles in healthcare. Okay, so like fine, okay, how do we make this a reality? Okay, how do we actually apply these first principles? And the big challenge is that historically, employers have been trying to do this within the existing healthcare ecosystem in their area. And the point is that it doesn't work. If you're trying to get back to basics and first principles and things that have been around for thousands of years, like you're not going to be able, that is essentially like a new trick, right? We need to do this a different way, right? Listen, you can't teach an old dog new tricks. So we basically spent decades trying to teach a bunch of healthcare system old dogs new tricks. And so the point with direct is that the employers can work directly, frankly, with mostly new healthcare organizations. So that, the other saying is you can't pour new wine into old wineskins because otherwise the old wineskins will burst, right? So you got to put the new wine into new wineskins, right? So a lot of these organizations tend to be newer, and they tend to be newer primary care organizations. And listen, at the end of the day, if you have coronary artery disease or you have cancer, et cetera, you got a bleeding stomach ulcer, listen, you're going to need specialty care. Like nobody in the world is saying that only a primary care physician is going to be able to provide you every type of care you need. Like that's not the point. But the point is that even the relationship with the specialty care is like, okay, it's direct specialty care. And then at the end of the day, like I always joke around, I'm like, listen, talking to me in an office isn't going to make you better. To a certain extent, I probably need to alter your biochemistry a little bit, and I probably need to do it with a medication, right? So you gotta do it with pharmacy. With medications, but believe me, like there's a time and a place to not take medication, but there's also a time and a place to absolutely take medication. I guarantee you, all three of my children would not be alive today if it wasn't for medication with their severe asthma when they were small children. Okay, so the point is that if you try to do the primary care and the specialty care and the pharmacy with the old dogs, you're not going to be able to teach them a new trick. And so you really got to go early. And what does that early look like? And this is where we're kind of talking about the bottom here, right? So you got early intervention, better relationships, and reduce costs downstream. Okay, what is the underlying current? Again, the first principle that um, enables all of that. And that is okay. I'm going to get a little esoteric here, but stick with me here.
Okay.
And that is love, right? If you think about care, right? It's called health care. Okay, fine. What's the most caring relationship anybody has ever had? It's with their mother, right? Everyone loves their mother. And I mean, us dads, we're okay, right? But like everybody loves their mother, and listen, mothers love their children, right? And
Right.
so, okay, fine. I went to this wedding one time where the pastor at the wedding said, "Love is spelled Time." I was like, wow, how true is that? And so it's really time, the time that has been taken away from doctors and patients because of fee for service. And so when you can directly pay for care, an employer can directly pay for care, not in a fee for service fashion, but more in a subscription fashion, then it allows for the physician to actually spend the time, just like the mom spends the time with the kids. It allows for the time necessary to do things like early intervention. It allows them to do things like form better relationships. It allows them to do things like reduce downstream costs. So, really, getting down to first principle, what's the ultimate first principle? The ultimate first principle is love. And to the extent that an employer can actually facilitate that, then they will accomplish their goals. And listen, in terms of that goal, like it's the triple aim, right? It's access, quality, and cost, right? I think that is the right triple aim, right? And the way that you accomplish that triple aim is through love.
So Eric, that all sounds really good. Like that's, that's really at the heart of it. When I think about what these models look like in the wilderness, these are no longer theories, right? We've got employers that are adopting these as just rapidly as possible, to sort of build on top of their Buka network. So talk a little bit about, what does a direct care plan, a direct care network strategy look like?
Yeah, and so again, this is not sort of theoretical. Like real employers are already doing this today, and it has very like concrete manifestations of like what you do. Okay, what does that mean? That means that the employer is paying directly for primary care on a subscription basis. In other words, you're not paying per visit or per stuff that's done, but you're paying for a person to be able to have unlimited, zero out of pocket cost access to a primary care physician 365 days a year. And that's typically taken the form of what is oftentimes referred to as direct primary care. And so that's the key. The key is that when you pay subscription, the physician is not motivated to just run through as many patients as they can so that they can bill more. And the physicians, like what that literally means is that their patient panel sizes are smaller. They're about 800 patients, and the typical fee for service primary care doctor has a patient panel of at least 3,200 patients, so it's over 4 times larger. And so, because the panel size is so much smaller, the rule of thumb is that your typical direct primary care physician sees about 1% of their patient panel per day. So they see about 8 patients a day. So that means that they're able to spend half hour, 45 minutes, an hour with their patients to be able to do the things in terms of like listening to them and actually getting an accurate history, being able to perform a detailed physical exam, being able to, as a physician, to teach the patient about what is going on and explain to them what is going on. And like so many times, that time allows for higher quality care. It's not a question of just quote unquote cheaper care. You're able to get like more accurate diagnosis. You're able to get better patient adherence. Okay, so like what's a prime example? Okay, so did you know that when a physician prescribes medication, that they only actually end up taking it half the time? Like if I prescribe you an antibiotic and you don't actually take it, well, guess what? We really haven't solved anything,
That's
right?
right.
And so why don't they take it? Well, to a certain extent, they don't necessarily even understand the importance of it, or they don't have a good. It's too expensive, or there's a breakdown at the pharmacy, or there's a prior authorization, or what have you. And so all of this is interconnected. So not only do we have the direct primary care, but this is where the employer is also paying for direct pharmacy services where the believe it or not, the generic medications, you're like, oh, generics are so cheap. They're $5 a month, right? These generic medications are actually so cheap that you could literally get a year's worth of medication for like $5. Okay.
Yeah.
Like it is really, really cheap. Okay, so there's a way to get your and generic spend is upwards of 80 to 90% of the actual medications that your employees are taking. And so by having the pharmacy directly, the order goes from the physician to the pharmacy and it gets mail ordered to their house. Now it can be in person, but a lot of times it is mail order, and you can literally do that. So not only are the office visits free for the patients because the employer is paying for it, but you can make a lot of the medications free as well because it's much more cost effective for your employees to actually take the medication than it is for that to go through your typical plan and they don't take it and they end up in the emergency room, what have you. And then that time allows for the relationship again to actually understand what's going on with them and to establish that trust so that, listen, because these primary care doctors have a direct relationship with all of their patients, they give them their cell phone number. And so much of this can be handled through a conversation or a text message. So you don't even need to come into the office all the time. And there's so many ways that what historically has translated into ER care can be just done through a trusted relationship with somebody who knows you, and you can call or you can text them and you can address what it is that's the problem. So, at a very basic level, the ER utilization in these direct care models, it goes down by like 60 to 70%. And every ER doctor will tell you that. They're like, yeah, the majority of people in this ER, they do not need to be here. Okay, that's fine, right? But not only that, but it also decreases hospitalizations by upwards of 40%. And I can tell you,
Wow.
as a hospitalist physician, I would see all these people now. I'm like, you don't need to be here. Like, why are you here? Right. And a lot of times it's like they're here for such stupid stuff. It's like, oh, you're on a diuretic medication for your congestive heart failure and you didn't get your Lasix filled. So you got volume overload in your lungs and you can't breathe. So of course you're in the hospital now so that you can't breathe. But ultimately, the reason why you're here is because you just didn't get your Lasix filled, which is like a very dumb reason for literally a $25,000 hospitalization. It's like a car. Okay.
Right.
So that quote unquote dumb stuff, like just getting your Lasix filled, literally costs the employer like a car in order for that to happen. And the same thing holds true on, so fine. So that applies to primary care services, but that applies to specialty services as well, where employers are directly contracting with specialists. And here's the key is that those specialist direct contracts can actually be for much less than your typical in-network rate. So you can actually get specialist services for less than an in-network rate. Now, why would a specialist agree to give an employer a better rate than a big health insurance network? Okay. So if you've been living under a rock for the past 20 years, like most doctors can't stand insurance companies. They hate them, right? Why do they hate them? They hate them because they don't pay. Like, wait, I
Right.
thought we had a contract here. They literally, sometimes the insurance company's like, yeah, we're just not going to pay you. And if you want us to pay you, you just need to sue us. Like, that's literally what they say. They're like, wait, we had a contract and you're just like breaking the contract and you're telling me that I have to sue you just to get paid, right? And so and even when they do pay him, it takes them 30, 60, 90 days to pay him. So like it's so the met you gotta understand, most specialists see a ton of Medicare patients. Okay. And so you're like, hey, we could pay you like 25% more of Medicare. And they're like, look, I'm seeing all these Medicare people. And if you can pay me actually more than what I'm getting paid for Medicare, and you can pay me faster and I don't have to sue you to get paid, I will take that deal. I think that's a fantastic deal. Right. Okay, so fine. So you can get a better deal. Fine. Right. Now, the question is, how do you get the plan members, the employees and their family members, to actually use those specialists who've given you a better deal? Well, that's where the primary care comes in. Is listen, you've got a trusted relationship. You don't try to quote unquote steer these people to the specialist when they need the specialist. You have to establish the relationship first and do the motivational interviewing and get to know that person so that if and when it makes sense for them to see a specialist, then they're going to go where the primary care physician tells them to go. And so historically, all that steerage is a horrible word. Like, what patient ever wants to say, I want to be steered? I've been looking around all my life to be steered. Who can steer me?
That's
Again,
right.
that sounds kind of un-American, right? I don't really want to be steered. I'm not a steer. I'm not a cow, right?
That's
So,
right.
okay, so this is, and oh, by the way, when the primary care doctor is involved with a specialist, then you have something called coordinated care. You don't have a quote unquote care coordinator from the insurance company who, again, I thought care coordination was my job as an internist, as a primary care physician. I don't really need somebody else to do my job. Like, that's, I don't really want somebody else doing my job. Like that's my job. So you can actually then have coordinated care between the specialist and the primary care physician for what actually goes on in the specialist office. And so what you're doing as an employer is you're not quote unquote rebuilding the US healthcare system. You're not quote unquote solving healthcare. But what you're doing is you're creating your own healthcare ecosystem. It's like a micro environment. Think of it like a greenhouse, right? You can make it look like San Diego all the time for your employees, right? You're not trying to do it to boil the ocean in America, but you can do that. And again, you're not even going to do it for all services, but you're going to do it for a lot of the services, right? You don't better is the evil of good enough. Okay, you're like, yeah, well, but there's one particular, like, listen, there's going to be some, you don't get rid of your health plan. Okay, you don't get rid of your major insurance carrier. You don't get rid of your network. You don't get rid of your ASO and your TPA. But the point is that you've got this ecosystem you've got an ecosystem of love to take care of your employees and their family members. And that ecosystem of love isn't going to literally cover everything. So you need to have that catch all for some services outside. And guess what? Rome's not built in a day. You can grow that ecosystem of love over time. So it can encapsulate more services and it can encapsulate more people. And oh, by the way, this is what Serigraph did in the company that solved healthcare. They did this almost 20 years ago, and they wrote a book about it, and it was written by the CEO of Serigraph, John Torrance. So if you want to, like, you're like, oh, this sounds so theoretical or whatever, like, no, he literally did this, and he caused his health plan trend to be flat for 9 years. And more
Incredible.
importantly, he had an employee quit, and it was a very senior employee. And during the exit interview, the employee was like, disgruntled about the way that he was treated at Serigraph or whatever. And he said, but I'm really going to miss the health plan. I really loved the health plan at Serigraph. What employee on the planet ever says that on their exit interview?
Right.
Okay, so they
Right.
loved it, and this is in Wisconsin, which John Torrance is famously called the land of beer, brats, and butterfat. Right? These were not necessarily the quote unquote healthiest employees. So here you had a health plan that was much lower cost that the employees loved, and it was working with an environment of employees who had a lot of health issues. So, like, this is, and oh, by the way, Quad Graphics did that in Wisconsin as well, and there's a bank in Kentucky that did this as well. There's a ton of, believe it or not, beer distributors in America that have done this for, like, the beer truck drivers of America, and it totally works. It's called BevCap. Okay, so again, this is not theoretical. Like, this has all been done before, and any employer in America can do this.
I love these strategies, Eric. Employer now gets to move away from a fee for service model. They put a front door of direct primary care on a fixed fee basis. The closest thing we have back to the managed care days of capitation. We combine it with a specialty care platform so that care that can't be provided in the clinic then goes into a specialty care platform where we have aligned incentives. That's super important. We combine it with a direct pharmacy program. Like, you put those pieces together and you now have really moved closer to aligned incentives, and you keep your Buca network to be able to access for things that can't be provided in that direct care strategy. Like, I love where this is going. And when you do go to the Buca network, we don't just go to any provider in the network, but we leverage what we've learned with alternative health plans to go to the highest quality, best efficiency based providers out there. And, when I think about, what it's going to take to align incentives and to bring a flattening of that trajectory of healthcare trends, and you and I beat this down, in our conversations for years. It's not more technology. It's certainly not more vendors. Like you said, nobody wants to be steered. We're not cattle. We don't want more restrictions. We need aligned incentives combined with these new network models, and ultimately not gatekeepers to control utilization, but gateways to get to the best care. I think we put all those pieces together, and I am more optimistic now than I've been in many years about what we know is possible. So Eric, give us the final word for today as we wrap.
Oh, again, I'll just use quotes. You can tell I love quotes, and that's where, listen. Thomas Edison said, yeah, innovation, typically just is dressed in overalls and just looks like hard work. And so I mean, it's like, listen, like everyone can do this. It's just the question of do you want it? Like that's really the question. Is like, do you want it? Like, do you want to wear the overalls? And guess what? Like more and more employers in America are like, yeah, I want it. I get excited about all this stuff because this makes such a difference for the individuals and their family members. I mean, I look at this as a public health initiative. And so you're like, oh, listen, I'm running a business. I don't really care about public health initiative. That's fine, right? It's a side effect of you caring about your business, but it's a wonderful side effect.
Dr. Bricker, really great to be with you this morning.
Thanks, everybody.